Okay, are we good? So the last survivors here. We're all here for this little bit of a marathon. I'm going to try and condense 2 days course, which we do in London in November, into 1.5 hours. So I'm going to have to speak very fast. Okay, and there we have the Slido up there, in case you want to, keep asking questions, and I can maybe interrupt and ask and answer. Okay, so what I'd like to do is to get a little bit inside the complications of corneal refractive surgery. And when I say a little bit, I'm going to dive very deep into certain parts of it. But I'm not going to get you everything, because you can't do that in an hour and a half. If it was that easy, I have one question, actually, is from the guys at the back. Are you recording this on the video or just projecting it? Are you recording the video? Yes. So, okay, good. So I don't have to video this myself, because I'm looking forward to seeing what this looks like. Okay. So, my disclosures, which have not changed since this morning. Now, about 120 years ago, Röntgen, he devised this method of imaging bone with X-ray. And this is a picture of his wife's left hand. I am sure that when he presented this to the, surgical meeting in Germany, everyone said, I don't need to see the bones. I feel the bone, and I know how to fix it. I'm sure there was resistance to something new, didn't seem necessary. But that is exactly the resistance that I got when I started looking at cross-sectional imaging with high-frequency ultrasound in the early 90s. And the Artemis, which is now called the Insight 100 from ArtScan, it took 20 years to get this thing commercialized. But now it's becoming obvious that in order to fix complications, we need to have a diagnosis first. And so the first part of this little mini course is to go through and talk about diagnostics. What you treat and the methods that we use to treat complications depend entirely on the diagnosis. So this idea that we have from industry, which is do topography-guided treatment, do wavefront-guided treatment, these are very, very simplistic ways, and sometimes they can actually worsen the patient. There's a lot of echo in here, isn't there? Sounds like I'm in a cathedral. Tap, tap. See that? Okay, so thankfully, we do have now a lot of options for OCT imaging. I have many devices, many OCT. I have 6 MS-39s, an Avanti, and 3 Cirrus 500s. In my clinic, I take imaging and diagnostics very seriously. I can talk a little bit about the different devices. The OptoView devices and the CSO devices are the best. The Anterion, there's no validation really of these epithelial maps that I've seen. There is some validation of Presbyo, but you can't really buy it. And the Cirrus can give you good images, but it's not calibrated properly. It measures about 10 microns thinner than it actually is, and Zeiss hasn't corrected that. But essentially, the best machine for all of this is the MS-39, hands down. And I just want to go back and show you why I still use ultrasound. And that is because, you see, this is a cornea that had a flap made, and 10 years later, you can still see the interface lighting up like a Christmas tree. And this is one of the reasons why ultrasound is still helpful, because you can see internal interfaces, which will be physical discontinuities, which you may not be able to see by optics, because there aren't any optical discontinuities, because glycosaminoglycans bathe interfaces and eliminate the optical interface within the cornea. That's why the cornea is transparent. So, putting everything together, these are 4 examples of surface topography from Placido rings. And from just looking at the front surface, we may be able to diagnose what's going on, but we may not. So here, this looks not too bad, maybe a little bit irregular. This, would you know what this is just by looking at it? Maybe not. How about this? What does this look like? Anybody? Ectasia. It looks like ectasia, right? Yes, you agree? Okay. So I'm going to show you now the epithelial maps underneath these topographies. So in this example, you have here a nasal hinge, which is short, and the ablation has taken place, and the ablation was truncated. So you have very thick epithelium where the underside of the flap and the bed were both ablated, so you get a trough that's filled by epithelium. This is actually an eye that is 25 years after RK. This here looks very normal, but the patient is really complaining because, and look at the epithelium, has concentric circles in it. And this ectasia is not an ectasia. It's actually a decentered hyperopic ablation, where the tracker fixated on the wrong spot and the surgeon continued to ablate. So there was ablation of the circle of hyperopia through the visual axis. If we go in the other dimension, we see the cross-sectional imaging. And again, you see the step here, you see the RK incision down to 90%, you see the ablation in the center, and you see a highly irregular Bowman's in the case where the epithelium was in rings. So you see, when I'm looking at a complex cornea, I am analyzing it not just from, I look at the front surface, but I want to know why the front surface has a problem. And I'm looking at the epithelial map, which tells me about the contours of the stromal surface, and I'm looking at the cross-sectional images so that I can see whether Bowman's is regular, whether Bowman's is missing. Like here, Bowman's is missing. That's because it had ablation with an excimer laser, and here it's not missing. So there's still Bowman's there. So I'm looking at all these different factors. So now that you're an expert at this, let's look at this topography. So would somebody like to tell me what they think this is? What do you think this is? You're all very quiet. You want to put your Slido up and so you can anonymously say things so that you don't trip up? This looks like a terrible decentration. Would you agree? That's what most people would say. Actually, if you look at the cross-sectional imaging, this is the horizontal cut. Multiple cuts all over the place, disruption of Bowman's, and if you look at the vertical scan, it's a complete disaster. There's a huge amount of stromal tissue missing from the middle, and as you can see, multiple layers. So you see, you cannot judge a cornea by its cover. You have to look at cross-sectional imaging. And by the end of this hour and a half, you're going to realize why you have to be, well, you really shouldn't do any topography-guided treatments for repair if you don't have cross-sectional imaging. And you will understand this by the end. This is an example of a topography after a Q slider -5 correction for presbyopia, which made a central island. The patient draws this around a light. This is the wavefront, but the epithelium has this donut around the bump. So you see partial compensation for the central island created by the Q slider in a myopic treatment. This is why Alcon now has commercialized their Q slider for presbyopia, but only for hyperopia. Because if you do it for myopia, you get central islands. So going back to anatomical diagnosis, I'm going to now go through a case. And this case is a patient who had PRK in 1995 and then LASIK in 2001, an enhancement in 2006, another enhancement in 2014, and then ended up with 30 post-op visits after that last enhancement in the left eye. The letter of referral said that the patient had epithelial problems under the flap, and that's the left eye refraction was plus 2.75 minus 525 at 172, best spectacle corrected 2040 minus 2. The other eye was also down one line of best spectacle corrected vision. This is the right eye topography. This is the left eye topography. Now, you could say this doesn't look too bad, but you're not quite sure what's going on, right? We're not quite sure. So let's look. That's the slit lamp appearance. Exactly. That was exactly my reaction when I saw that. I was like, what am I looking at here? I have no idea what I'm looking at. I really, like, what is going on here? It looks like a Jackson Pollock on the cornea. Well, you put fluorescein in the eye, and you realize that there is a sort of heart-shaped, smooth area here. There's a sort of fold, looks like some kind of gap here. And over here we can see that the part of this half of the heart shape here has reticular haze inside it. And it has epithelial ingrowth under what looks like the flap, and that looks like the edge of a flap. In other words, this must be molten area, like melt, with no stroma. And you have direct epithelial stromal contact, which means that you get chronic inflammation from the epithelial ingrowth, causing reticular haze. So now we're going to look at cross-sections of this. Here's an opto view cross-section through here, where we see the flap ending here, right here. And then you have the reticular haze along here. And then you have a bit of flap down here. And you have epithelium under that stromal component of the flap. Here's another cut. We go through here. You're coming from flap to an edge where the flap ends. Then you have reticular haze right here. That's this little nubbins here. And then here you have epithelium under the stromal component of the flap. So this is all epithelial ingrowth here, right? And you spend some time at the machine looking at the cross-section and trying to build a three-dimensional picture in your mind of what you're looking at. This is the ultrasound image of the same eye, the horizontal and the diagonal. So you can see that there's different layers. And the other angles. So I said to the patient, you have multiple planes, you have epithelial ingrowth, you have haze, which is reticular, and you have a highly irregular astigmatism, and I cannot tell you exactly how I'm going to fix this. So what I need you to give me informed consent to do any procedure. I want to take you to the operating room, and I want to examine your cornea under the microscope in layers. I'm going to open the flap, I'm going to do a physical exam. And you remember in medical school, they used to call it an exploratory laparotomy. Do you remember that? When they weren't sure if it was an appendicitis or something else, or a bowel obstruction from adhesions. So you do an exploratory laparotomy. So I said, I need to do an exploratory keratoplasty. So I consented him for multi-stage LASIK enhancements, flap lift with repositioning, PTK, PRK, PTK for corneal irregularity, flap removal. I wanted the option to maybe remove the flap. And so here's where we're starting. And what I decided to do was to map this out so that I know exactly where I am. And I print this and I bring it to the OR. And I look at it upside down so that I'm looking in the microscope, but I've got my reference image here on the side. And so what I did was I started opening the edge. And we're sort of trying to do the thing. And then I sort of get the edge, and it opened very easily. So I realized that the epithelium that was under this flap was actually quite easy to remove. And so I decided to, because the stromal component of the flap was quite rigid still, it wasn't thin, it wasn't very melted, I decided to preserve those two wings of flap and to do just a clean out, only. And then I decided to suture the edges, just to make sure that the periphery doesn't get ingrowth, because obviously his problem started because of the ingrowth. And, suture. So this is one of the reasons why it's a pretty good idea to have cornea training before you are a refractive surgeon, because, you might need to use all of your skill set. I do suturing maybe 2 or 3 times a year now, so it's a little bit slow. But thanks to the magic of movies, I can make it look like I'm a really slick suture. Okay? So the treatment really was essentially lifting the flap to the purple line, and in the central scar area, leaving the epithelium intact, and then removing the epithelium and leaving a little buttonhole that was created here, where there was no stromal component of the flap, putting in 8 sutures and a bandaged contact lens. So this is what the patient looked like on post-op day 1. And this is at 2 weeks. And you can see that I can tell that there's a little bit of epithelial ingrowth which is returned, obviously from this side, from inside. It was too thin and too central for me to want to put sutures in there. So I was kind of expecting that, but that's okay, because at this point what I do is I put very low energy spots in there, very low energy YAG spots into the interface, about 0.4, 0.6, just enough energy to make a bubble. And actually, it has a really effective way of activating macrophages, so the macrophages come and chew up the epithelium for me. This is what it looked like at 3 months. So we'd reduced the cylinder considerably, and we gained a little bit of best spectacle corrected vision, but we still had a relatively irregular cornea. But if you notice, the haze is a little bit less. Do you see that? I didn't use mitomycin, I didn't do a PTK. And then at 7 months, the cornea was even more regular, and the haze was even more reduced. And the best spectacle corrected in the cylinder went down a bit more. And so basically in 7 months, we went from plus 225 minus 525 to plus a 0.5 minus 0.75, and we gained a little more than 1 line. This is the pre, and this is 7 months post. So topography-wise, we've made a huge improvement just by cleaning the epithelium and letting everything heal up. Now, why would I have done just that rather than doing more? Well, because in therapeutic refractive surgery, you cannot put stroma back. So if you can preserve stroma, that is a good thing, because you can use stroma for topography-guided treatments. If I had amputated the flap, I am now compromising my options in case there isn't enough tissue to do regularization by topography-guided treatments. So my aim here is to clean the situation up and preserve tissue. And as you can see, by 1 year, things were looking actually a hell of a lot better compared to where we started. So, finding out the actual cause of the irregularity is what guides you as to what to do. And I call that first case the knife and fork case. Because I'm not using a laser, I'm doing nothing fancy, I'm using a knife and a fork, and I'm just manipulating things, suturing, cleaning the situation out, no laser involved. And look at how much improvement you can get just with knife and fork. But of course, we want to move on to what we would do next. I can't hear. Can you use Slido? Come up here and say it loud. Or do we have a microphone? Do we have a microphone? Can we put the microphone here at the front? Did I do nothing? So you speak into the microphone. That's right, I did nothing. So what happened here was the ingrowth was causing chronic inflammation. The chronic inflammation was chronically activating keratocytes, turning them into myofibroblasts, which laid down reticular haze. By taking out the epithelium, 1, I regularized the surface. 2, I removed the haze because I removed the injury, the reason for the haze. So I've really cleaned up the situation here quite a lot. How we proceeded from here, I think, comes a little bit later. But first, let's just go to understanding how the basic approach to corneal refractive surgery complications is to divide everything into simple aberrations and complex aberrations. Simple aberrations is coma and spherical aberration. Complex aberrations is irregular corneas. If you have coma, that's a regular irregular cornea. It's regularly irregular. But if you have lumps and bumps all over the place, that's an irregular cornea. And that's the subdivision that we want to go for in the beginning. And we're going to move on to part 2 here, which is talking about these two options. So, let's go to simple aberrations, okay? Simple aberrations are spherical aberration and coma, like I said. We published the first topography-guided retreatment paper with corneal wavefront topography-guided treatments in 2009. This was with the Tosca software, which was modified from the MEL 70 onto the MEL 80, and we showed that you could expand an optical zone, you could recenter an optical zone with asymmetric profiles, and in this study we really showed massive improvement in these regularly irregular corneas. So spherical aberration, if an eye has very high spherical aberration, you can reduce the spherical aberration with one of these. And remember, I talked about this yesterday in terms of what spherical aberration is, the fact that the brain can filter quite a lot of spherical aberration, so you don't have to make it 0 to make the patient be able to see things. But if you have a toxic level of spherical aberration, this is let's say, 0.55, and then a toxic level would be 1.24, that is completely abnormal, and that would need fixing. And this I had both very high spherical aberration and very high coma. So in our topography-guided treatment, we showed that it was much more effective than wavefront-guided treatments. So when we matched controlled for pre-op spherical aberration and coma, we were able to reduce the spherical aberration far more with topography-guided treatments than wavefront-guided treatments. There's a number of reasons for this, the main one being that wavefront-guided treatments are limited to the pupil size. And so, whereas at topography, you measure the whole cornea. So you can do a 7 or 7.5 millimeter zone on a topography-guided treatment, which you maybe can't do on a wavefront sensor that doesn't go out that far. Anyhow, in this publication we showed, incredible ability to reduce coma and spherical aberration. We had the ability to take a very, very small Vizix central hyperopic terrible ablation and turn it into a reasonable, better centered, wider ablation. That's the difference map. Coma, of course, is also correctable, and we come to a case report which teaches you everything you need to know about centration in refractive surgery. So this is the patient who presented with this topography. Forget about the way that he got that topography. And in the wavefront measurement with the Waska, which was 4 times the resolution of all the other aberrometers at the time 20 years ago, we had a lot of spherical aberration and no coma. But you can see that this looks like a decentration, doesn't it? How can you have a decentration with no coma? Any ideas? Well, there's a huge angle kappa, and the angle kappa is inferior. So the surgeon centers the procedure on the pupil, which is superior. And so the treatment is centered off visual axis. And if you do a topography wavefront, which is centered around the vertex, you actually find huge coma. You also have spherical aberration, but you have huge coma. So this is interesting because you have the same eye measured with the highest resolution wavefront sensor available in the planet at the time, and a corneal aberration map. And they're 2 completely different set of aberrations. And then you look at creating the ablation profile for each of these, and the ablation profile for the wavefront treatment is completely symmetrical, and the wavefront profile, ablation profile from the corneal wavefront is completely asymmetric. So, doctor, you have 2 devices producing 2 different ablation profiles on the same eye. Which one are you going to pick? There's one company that said wavefront guided is the best, and there's another company that said topography guided is the best. And it's the same company providing both these maps on the same device. Now, this is why it's so confusing, right? Because just thinking about it as like, oh, I'm going to put that tube. I'm going to use the screwdriver. Oh, that didn't work. All right, I'll use the pliers. Oh, that didn't work. Well, So obviously, it's kind of obvious that this looks decentered, and I'm going to use this profile. So I did use that profile. And when you look at the corneal wavefront, the coma went down from 1.93 to 0.29, which is like normal. The spherical aberration went down. But if you look at the pupil-centered wavefront, which is from a wavefront sensor, the coma didn't change. The spherical aberration went down, but the coma didn't change. Remember, topography wavefront is measured from the vertex of the cornea. Whole eye wavefront is measured from the center of the pupil. So if there's an angle kappa, they're not going to be the same. Now, you can see why a wavefront guided treatment would not have helped this patient. It would not have changed the asymmetry around the visual axis. Other examples of fixing coma with the same system. And here's an example of a small optical zone with a Bausch and Lomb laser, and use a topography-guided treatment to increase the donut of epithelium further out and better centered. Here's an example of another hyperopic ablation, a +4 done on a BNL 217, very small optical zone, and only 5 millimeters, even though it was programmed as a 6, and you can expand that to 7. So we published a paper specifically on regularly irregular astigmatism, so zone enlargement and recentration only. And what I wanted to do was to look at my series to know what the chances are that I would need topography-guided treatments in my practice. Because there's a lot of people who have excimer lasers, but they don't do topography-guided treatments. They haven't paid the extra for the software, or whatever, or the system doesn't do it. Like, you know, NIDEC doesn't do it, Vizix doesn't do it. So you have a system that actually doesn't even do it. So you bought a machine, you bought a car without seat belts, yeah, without airbags, because you can't repair, you can't be ready for an accident. And out of almost 10,000 eyes, I needed to do 73 topography-guided treatments, which means that the probability of an expert refractive surgeon, if I might call myself that, the probability of an expert refractive surgeon is going to need topography-guided treatments to help their patient is a little under 1%. So if you do 300-400 eyes a year, you're going to have 3 or 4 eyes a year that are going to benefit from topography-guided treatment. It doesn't sound like it's not worth spending the money on the topography-guided treatment. I disagree with you, because if you don't repair that complication, the patient's going to go online and get depressed, because they're going to find other people who have not been repaired, and then they're all going to form a little bubble, and then they're going to, you know, rile themselves up, saying that doctors are terrible people and LASIK should be stopped. And they're right, because they're suffering and they've been told there's nowhere out. Or you can say, listen, I don't do this, but there are people who specialize in this, and, you know, you should go to this surgeon, and I'll write to him and I'll connect you with him. So with the topography-guided treatment with the MEL, we have really good accuracy on refraction. And now, you know, other systems, you often will tell the patient it's going to be 2 stages. 1, to smooth the cornea out, and 2, to do the refraction. With the Tosca, we tell the patients there's only a 20 to 30% chance that you'll need a second procedure. It's not as accurate as a primary procedure, but it still is pretty accurate. So if I have a plano patient with night vision disturbances, the chances are they'll still be plano after I've done the topography-guided treatment. This is this is all of the centers of the ablation, the centers of the pre-op decenter treatments, and this is the post-op, showing you that the centration ends up being with a bias of 0.2 millimeters with a standard deviation of 0.14, which is exactly the same that we get with our primary treatments. That's how good the centration is on primary treatment. So we're converting a completely distorted decentration population into as if there wasn't a decentration group post-op. There is massive reduction in spherical aberration in coma, and you know, this is an incredibly effective treatment. So topography-guided treatment is more effective for both spherical aberration and coma reduction because it's based on the vertex of the cornea, not the center of the pupil. It respects the visual axis, not the pupil center, as in wavefront correction, and all of the aberrations that are seen from the perspective of the patient, which are centered on the vertex, not the measuring device, which is the center of the pupil. It's pretty accurate in leading patients emetropic, and it can be used for both myopic or hyperopic decentrations or zone expansions. And actually, it takes less tissue than wavefront-guided treatments. So don't forget, however, that higher order aberrations are good as long as they're not in a toxic level, because higher order aberrations increase depth of field. So we got to keep that in mind, because like PRESBYOND works on the fact that higher order aberrations are good. So if we go on to part 3, we're now going to talk about irregularly irregular corneas. So we've talked about regularly irregular corneas and topography-guided treatments. And I'll mention that, yes, so the topography unit that connects to the MEL90 is the Atlas. And that is shortly going to be moved over to the MS39. So it's already in the works. What was I saying? Topography-guided treatments. When we do the full course in November, we will talk about the details of how you program a topography-guided treatment. And it involves 3 levels of vector analysis and an MS39 and an Osiris, because we need to know the front surface, the back surface, and the lens astigmatism, because that's how you get the whole thing to work in one way. So I'm going to go on to irregularly irregular corneas. And how many people here remember George Waring III? Yeah. Lovely guy. He was like he was total, absolute mentor to me. And I felt, I was in my 30s, and I became very good friends with him. He loved jazz, and whenever we went to the Academy or the ASCRS, he would accompany me. We would go to jazz clubs. I would sit in with the band. He was like my agent. He would go up to the band and get me on stage, And we were skiing together one weekend, and he said, you got to publish your stuff, man. You got to send it to the JRS. I know. I said, it's interesting, because I don't think anybody has ever described this fact that the epithelium fills all these nooks and crannies and smooths out the stromal surface. He said, I think if you look in the 1921 textbook from Alfred Vogt on how to use a slit lamp, I think you might find something in there. So I go online, I find it at a secondhand bookstore, they have a copy. $50, I open it, and I find corneal stromal defects are filled with surface epithelial cells, 1921. Pretty good, yeah? There's no such thing as a new idea. So I don't mind being second to Alfred Vogt. Anyhow, what we learned from measuring the epithelium in 3 dimensions was that the epithelium changes no matter what you do to the stromal surface. If you change the stromal surface, you will change the epithelial profile. So in all situations, so if you have steep areas, the epithelium will thin. If you have flat areas, the epithelium will thicken. So right when I started doing this is before I started really publishing a lot on this. This was ARVO 1994. I had a poster at ARVO called Epithelial and Corneal 3-Dimensional Ultrasound Pachymetric Topography Post-Excimer Laser Surgery, where we're examining irregular corneas. And the overall poster conclusion was what we now call the law of epithelial compensation, which is that if there is irregular astigmatism, there is irregular epithelium. Guaranteed. Why? Because if an eye presents with irregular topography, by definition, the epithelium has reached its maximum compensatory function, leaving irregularity on the surface. If an eye presents with a regular topography, the epithelium might have fully compensated for the stromal surface irregularity, and so you cannot see it. But if the epithelium can no longer compensate for what the full irregularity in the stromal surface, then the topography will be irregular. Okay, so that simply means irregular astigmatism, irregular epithelium. Yes, it's very good news that the MS39 is being connected. I agree. So here's the problem with blind repair work, which is what some of the companies push surgeons to doing. There's one company that says that everybody should have a topography-guided treatment all the time. And this is really not very scientific, because you see, you can have three exactly the same surfaces with completely different stromal surfaces. So these are not the same eyes. It's not the same optics. So the rules of epithelial healing, which I first presented at the Academy in 2012 in a keynote lecture, the epithelium always thickens to fill depressions. The epithelium always thins over peaks, thickens over troughs, it thins over peaks. The epithelium is changing proportionally to the amount of stromal change. So if you do low myopia, you get less epithelial compensation than moderate or high myopia. If you do a hyperopic ablation, the central epithelium gets thinner the steeper you make the cornea, but the more ablation you do, the thicker epithelium filling the trough gets. Keratoconus, the more severe the keratoconus, the thinner the epithelium gets, and the thicker the donut around it gets. The amount of epithelial change is also proportional to the rate of change of curvature of the stromal surface. So if you have a very small irregularity in the stroma, for example here, in this was one of the very first scans I did in a human. This was at Cornell. The patient had a corneal ulcer which had healed. And I scanned the patient. We only had a very narrow window. And you can see it's a 200 micron epithelium in a 1 millimeter diameter. So it was a little punched hole with a 200 micron fill of epithelium. And that's because the rate of change of curvature is severe. And so the epithelium does 90% compensation. If you have an example here where the hole is bigger, so for example, a 4.5 millimeter hole instead of 1 millimeter, you get 40% compensation. That is exactly what was happening when we were doing PRK in a 4.5 millimeter zone in 1994. So we got a lot of regression when we did a PRK for -3. The patient could come back -250 because the epithelium would really fill the hole. And David O'Brart, while he was John Marshall's fellow, he was the one who published these papers showing that if you make the optical zone wider, you get less overshoot and less regression. And that's because the lower the rate of change of curvature, the less the epithelium compensates. Obviously, no one has a monopoly on good ideas, and within a few years later, Paulo Vinciguerra also was working on using the NIDEC to expand the transition zones. And he would do a 6 millimeter ablation zone with a transition to 10 millimeters. And he was showing that there was very little regression or very little change in the epithelium because the rate of change of curvature was very, very shallow from the periphery to the center. So he calls it curvature gradient. So the whole point here is that you cannot judge a cornea by its curvature, by its map. you have to measure the epithelium. And I don't know how much you're aware of this, but I've published, if you remember, I started measuring the epithelium in 1991. I made the first map of the epithelium in 1993, published 2 papers in ophthalmology in 1994, and it wasn't until 20 years later that anybody else could map the epithelium commercially. So I had 20 years of people ignoring me and saying that there was no need for epithelial measurements. And so I published about 50 papers just on the epithelium. And that means that all my friends, they think that I'm very shallow. That's a joke. Can I have a little bit of a, are you alive? Are you awake? Okay. So let's go back to these cases, right? So we're going to look at this first case here. And now we're starting to get into what we do about it. What do we do about it? So we have a very irregular cornea. And we published this paper as a teaching example of how you fix highly irregular corneas. So this guy had a low hyperopic LASIK done on a 217 with a Moria disposable which had a nasal hinge. And post-op one day, he was overcorrected as expected with the 217, huge overcorrection because it's a small optical zone. But the surgeon diagnosed a decentration. And a few months later, he did a topography-guided treatment to improve the decentration. Now, the refraction improved a bit, but the patient was still complaining of night vision disturbances. So he said, well, the topography-guided treatment didn't work, so I'm going to do a wavefront-guided treatment. He did a wavefront-guided treatment, and now the patient got worse. Now he said that he had double vision, ghosting, headaches, starburst halos, glare at night. The surgeon is in England, north of England. He referred the patient to me. The patient, when I saw him, was plus 0.75, minus 0.75 at 75. He was best corrected in 2016, but he had a lot of night vision disturbances. And you can see why. His whole eye aberrations were huge amount of coma, like astronomical coma, astronomical spherical aberration. And he had practically no angle kappa, 0.2, 0.1. So the whole eye wavefront was basically the wavefront. Now, the fact is that with cross-sectional imaging, I was able to show that this was not a decentration. This was actually the anatomy of the flap. And we can see that the flap interface actually finished short of where it should have been. And the stromal surface had a highly irregular dip here nasally. So the epithelium basically filled the hole. So the hypothesis was that the flap was created and lifted. The hyperopic ablation was done, but unfortunately, the nasal hinge wasn't protected, and so there was ablation of the underside of the flap and the bed, essentially in the same location. So when the flap went back, the stromal surface, of course, collapses, and then the epithelium fills that. And that's exactly what we see here. We see filling of the trough and thinning over the bump, the rules of epithelial healing. So how do you fix this? Because actually, if you look carefully with the fluorescein staining, you have negative staining because of the huge ridge here, because of the double ablation. So because you are now experts at diagnosis of corneal complications, you now understand why topography-guided treatments and wavefront-guided treatments were the wrong approach. Neither of these represent the stromal surface irregularity. They represent the front surface of the cornea. The wavefront is, 70% refraction at the front surface, and the topography is the front surface. So you're treating the wrong information. That's why these two treatments failed. And so the treatment in this case is actually to get rid of the bump. And that's what transepithelial PTK does. you take even layers out and you break through the epithelium and start lobbing off the bits of stroma that are sticking out into the epithelium. And so let me just show you diagrammatically. What we do is we can simulate the epithelial removal pattern. So if the thinnest epithelium is 41 microns, and you get a breakthrough right there. If we go to 47 microns, we have breakthrough here and here. So you can see we're going to start taking stroma now from that hole and that hole. And then we go to 59 microns, we're going to take more, and then 65, we've removed almost all the epithelium. We're just leaving a little bit here. So that stromal removal is as a result of the epithelial pattern, which is irregular. And we can actually, therefore, plot how much stroma is going to be removed if you do a transepithelial PTK, because it's a mirror image of the breakthrough pattern. And so now we can compare the amount of stroma that's going to be removed by a transepithelial PTK with what the topography-guided treatment from the same eye would have done. And as you can see, the patterns are quite different. And where the maximum tissue removal is going to occur, that's actually outside of where the maximum tissue removal is going to occur by topography-guided. That means that you're ablating the bump slightly off-center, which means you're going to deepen the crevice and increase the bump. And so if you have even a tiny decentration, instead of taking the bump out, you'll increase the trough. Now, how do you do a transepithelial PTK? This is where you pay attention. So let's flip everything around to the surgeon's view. And now let's look at that section and represent it here diagrammatically. And then let's look at how this looks intraoperatively. So you put the speculum in, you very gently dab the cornea dry because water absorbs the excimer laser. And then we program a PTK to 49 microns. Why 49 microns? Because we looked at our transepithelial PTK simulation. And at 49 microns, there's a very distinct pattern of breakthrough that we expect to see. And we see it here. Breakthrough here, breakthrough here. It's almost exactly what we predicted, right? Now we know that that the epithelial ablation profile rate that we're using is correct. And so now what we do is we do a second ablation. And now I'm going to go down to 65 microns. Now I get to 65 microns, I'm actually leaving a little bit of epithelium behind, that's this little bit here. And that's exactly what we find at the end of the procedure, right? So we have predicted the breakthrough pattern, and we have verified the breakthrough pattern by having what I call the photo stop opportunity. You know when you're driving in the mountains in the Alps and it says photo stop opportunity, and you park the car and you take a picture and then you get back in the car and you carry on. So this is the photo stop opportunity. Now, why did I stop there? Well, there's still a bit of irregularity. Well, if I carry on and take that out, I'm also taking a lot of stroma away that I don't need to take out. So what I do now is that I know from experience that the 65 micron PTK in this shape is going to induce about a +1 hyperopic shift. So what I'm going to do now is I'm going to program a +1 ablation. That +1 ablation takes very little tissue out of the center and more from the periphery, which is going to take out that last piece of epithelium that's here and smooth out that ridge 100% without taking more central tissue. And so we end up with no epithelium. However, we have a very irregular surface because this surgeon uses too much irrigation and doesn't know how to do the zero microfold technique for flap replacement, which we teach at our course. And the way you treat that is by what we call wet PTK. So the wet PTK protocol is to flood the cornea with water, and then what happens while you're ablating is that the peaks are sticking out of the water. And so as the ablation hits, it hits the peaks only, but it's absorbed by the water around the peaks. And so you actually get a smoothing effect because you're only taking out the peaks. So here I'm using some anesthetic because it's been a while since we put more in. I'm ablating the water. It looks like a magic trick because it looks like you're doing nothing. But at the end of the one wet PTK, look at the surface. Really, really smooth compared to how it was just before I smoothed it. Yeah? So the wet PTK technique is great for polishing the surface of small microfolds. And so this is the result. We had this cross-sectional anatomy before. We completely regularize the bump. The epithelial profile gets regularized. It's almost like expanding the zone. There's the difference map. The topography is improved. Even the negative staining goes away, and the patient is, super happy and on target. So we'll go to the second case, which is this other one, which had this highly irregular Bowman's. We published this actually in 2006. This was one of the very first therapeutic cases I ever did. And this, you have to understand, I spent about 10 years scanning complications and just scratching my head, like literally not knowing what to do. And here is where we were starting to understand what to do. This was the first one. This was a NASA engineer who came over from Florida. He found the website, he found the fact that I had the Artemis, the Insight 100. He said, you look like the only guy who can diagnose things. So he said, the problem with my eye is that the eyes feel like they're fighting each other. He's an engineer, right? Low contrast, it just sees differently. He said, it looks like waxy vision. That's what he said, waxy vision. So his history was a -6 ALK, followed by some AK incisions, followed by a LASIK for hyperopic cylinder, followed by another LASIK enhancement and another LASIK enhancement. And he presented to me with -0.5 at 80. So, not that much refraction. And as we said, not too irregular a topography and not too terrible a wavefront. But he had very low contrast. And his orb scan looked pretty normal. However, the cross-sectional imaging was nothing like that. The Bowman's was highly irregular, and the epithelial pattern was thick, thin, thick, thin. So he had rings of thick epithelium. And the epithelium has a different refractive index to the stroma. So he basically had an array lens of epithelium on his stroma. And you remember what the patients who had the array lens put in, they used to say, my vision is waxy. So it was literally incredibly the same. So you do a transepithelial PTK, and you completely regularize the stromal surface, you regularize the epithelial profile, you regularize the cornea, you decrease the aberrations, and you jolt the contrast sensitivity back to normal. This is the photostock opportunity at 55 microns, and you can see the ring of epithelium that we expect, a little bit here. Everything looks exactly as expected, and this is a stromal difference map showing the rings of stroma that were removed to regularize the stromal curvatures, these rings that were there from each of the successive treatments. Now let's go to the next case. This is radial keratotomy. And this patient is another teaching case report. So this guy had RK in 1982, Can I have some water, like a bottle of water, perhaps? Ah. Like this. So you can do your first LASIK and then lift the flap, and then you lift the flap with your special technique, which we teach in the course. And then if you get some scarring, then you plan another flap wider, deeper. And if you have OCT, which you should have because it's 2025, there's no excuse, you need OCT, you need the MS39, because you need epithelial mapping and anatomical mapping to be a real refractive surgeon. And so you have to have this device if you want to do good surgery and sophisticated surgery. But wider, deeper is one option. And there's a special technique for lifting wider, deepers. You can see here, actually you can see it here, right? This is the original flap, and that's the new flap, yeah? Original with a little bit of a scarred edge, new flap. There's also the option of doing, yeah, it's complicated. This is a whole lecture, okay, on how you do all the flaps. But there's another option, which is to do an in-cut. So if you have an original flap and you can't use that edge again, you do an in-cut inside, a side cut, and lift that flap. Okay, you mark so that you know where you are. Let's say you've got a little edge problem here, and then you have the little ingrowth that was there, and you make the in-cut to avoid it. And here's the video of doing that, where you're making a side cut only inside the edge, and then you lift it the same way that you lift, and you're on a clean edge on a clean bed. Yeah, so that's another way of using the same flap. There's the original flap, there's the new flap side. You've got a little ingrowth, you can avoid it doing an in-cut, you see, inside the original edge. Inside the original edge. Yeah? So that's how you do LASIK 6 times in the same eye. So for me, PRK is last resort. Yeah? I mean, it's like, I'm really sorry, I have to do PRK. And then you got all these people saying, oh, trans-PRK is fantastic. And no, it isn't. Actually, trans-PRK is worse than PRK. And don't get me started, we're going to be here another hour. That is a bad procedure. We don't have perfect mapping of the epithelium for transepithelial PRK, and so the results of trans-PRK are worse. I would like to share that lecture. You know what? I think you should all watch this lecture, because that way, PRK, Reinstein, let me see here. If I find the lecture here, there it is. So here it is. This is the lecture. You should watch this in your own time. In fact, the Reinstein Institute, I have tons of teaching videos there, which you can watch. The share code, take a picture. Oh, it's a bit complicated. How do I get this to you? Copy. Okay, ready? This is how we're going to do it. We're going to do this on the fly here. We're going to go like this. We're going to go like this. We're going to go like this. QR code generator. And then we're going to make a website. And then we're going to put that there. And there's the code. Okay, so you can go here. This is the QR code to the PRK lecture. 30 minutes will change your life. You will never want to do PRK again unless you have to. So we only do PRK if we have to. It's a therapeutic procedure, or there's a scar in the middle of the cornea, or there's recurrent erosion syndrome. But apart from those reasons, LASIK is much better. Okay, so you've got that for free. That's included in the this morning's fee for the okay. We need to perform enhancements of both eyes with PRESBYOND done Should we still do it using the presbyond software? Good question. So usually no. You just use the AAA profile. Because the enhancements are very small corrections. It's +1, -1, plus 0.75, minus 0.75 sil. Just use the AAA profile. You're not going to change the spherical aberrations very much. Plus, if you use the AAA profile, it's free. You're not paying a license fee. Okay? If the Z4.0 is more than 0.8, what do you input into the software? Well, you enter whatever it is. Let the software do the work for you. Right? You have a shot of tequila, let the software calculate it for you. Patient over 40, corneal and less spherical aberration is constantly changing. You treat them at a certain point in their life, what if their spherical aberration changes? Right. So that's an interesting question, because I don't think any of you have ever measured the spherical aberration of an eye over time in someone under the age of 40 to even ask this question. But what you're really asking is, what happens if the spherical aberration changes in the eye? And the answer is, it doesn't matter. Because remember, it's not a target spherical aberration, it's a zone. So if the spherical aberration is at 0.5, and it goes up to 0.6, or, well, so what? It's the same. Yeah? If the patient has a cataract, well then the corneal spherical aberration gets balanced with an intraocular monofocal lens. Any more questions down here? Can we scroll around up and down, up and down? Notice that some smile monovision doesn't work. Yeah, that's because you don't have the EDoF, because you don't have... We haven't published this yet, but we've analyzed smile monovision with matched controls, and the vision is better with PRESBYOND. Smile is more accurate in high myopia, so the percentage eyes that are 20/20 with one treatment is higher with smile. But the near and intermediate vision in particular is not as good with smile monovision. So, for patients who had previous myopic LASIK PRK, and now they come in presbyopia, presbyond is an excellent choice for them. Thank you for that comment. You put in the spherical aberration into the software, and you do the enhancement. ABC, as simple as that. Any more questions? Please scroll around. For patients have to yeah. Any more? Any more? No? Is that it? Did we answer everything? Oh, that's the latest question. No. Yeah, that is the latest. How are we doing for time? Are we supposed to finish at 10? Or 9? 30? Have we run over? Are we supposed to finish at 10? Oh my God. I'm on time. That's very unusual. Thank you. Listen, let me just point out that I'm running around all of these talks, and I just want to make sure that you all have specific access to the actual details of this. This is number one, which is that this is a refractive surgery textbook. It's not just a smile textbook. It's everything. It's how to refract, how to do +150 tests, how to get informed consent from a patient, which is bulletproof, the consent forms, how to talk to a patient during surgery. It has a script about that. It has pictures of a tray for your nurses to set it up exactly the way you want. It has a whole chapter on instruments and the different advantages of the different instruments and disadvantages. It has 16.5 hours of me narrating in full detail the intricacies of a complication and how I got out of trouble. So it's a big text. And it's not made by Slack anymore. Slack divested from ophthalmology, so they don't do any more ophthalmology books. And they sold it to another company, and I forget the name, but that means that sometimes the scratch number to get to the videos goes to the Slack website, which doesn't work, and they should have put a sticker in it, which takes you to the right website, just letting you know. Okay, and then the other thing is, just to finish here, 3 things. One, the next forefront refractive surgery course is next May. It's a beautiful time to come to London. It's spring. It's slightly, starting to get warm. Well, what we call warm, 23 degrees. You call that freezing. Give me my sweater. I need my ski jacket. Here. Okay, but this is a course which we very much encourage trainees to come to. So we basically charge them nothing because we need them to come, and we have agreements with the ISRS, the RSA, and if you come for the 2nd or 3rd or 4th or 5th time, which a lot of people do, you only pay half as much because we like to encourage people to repeat the course because there's too much information to learn in one. And then once you've done, and by the way, you can do this course live, but you can also do it online. So online is an exact video replica of the one we just did. So the course we did a month ago is now online for the next year. So the QR code takes you to the website where you can do the online version. And then in November, we do the therapeutics. So we talk about advanced diagnostics, how to diagnose a complex cornea, what do you look at, how do you decide what to do with a corneal refractive surgery complication, how to manage it. And we talk about ectasia management, but we're really talking about irregular astigmatism most of the time. But you have to do the first course to do this course. So it's too late to do the live course, so if you do the online course, you can come to the therapeutic in November. And then finally, before next year, you can come to Bangalore, where we decided, Sri Ganesh and I, to join our courses. So I'm going to do the theoretical part, which is basically our London course, and then he will offer practical surgical experience in his hospital after the theoretical. So it's a full package if you want to do everything, including theory and practice. And of course, the fee is much, much lower because, we don't have the same expense structure as Central London. So I encourage you to get in touch. You've got my email, which is at the bottom of every single slide here, right there. And we are now going to go to the next session. But just before we go, since we're all having so much fun here, and we're really having a great time, are we not? I think we should do this. I think we should do this. Hold on. I'm going to find it here. 1 second. Give me 1 second. Course, presbyopia, cataract. Okay. And, yeah. Here's what we should do. I would like to do this. I would like to take this picture, and I would like to go here to our favorite new friend here. And I would like to go here and say, what? Sorry, I can't type sideways. Hold on a second. Yeah. Ready? I rest my case. But what we haven't done is this. This watercolor was given to me, Dan Reinstein, by Chick Corea after I did his PRESBYOND. Can you interpret the art? Double-faced figure, perhaps a metaphor for binocular vision of the integration of different visual planes, echoing the essence of presbyond itself, merging near and far focus into a single harmonious percept. The top portion, which resembles a triangular gesture with red polka dots, could be seen as a representation of joyful perception of whimsical clarity, but with a surreal twist. It contains a single central almond-shaped eye. The central third eye might symbolize awakening or enhanced perception. Chick's experience of his new vision through laser-journey vision. He inverted the triangle with its deep blue lines may also evoke a prism or even a refractive map and nod to the optics of corneal surgery. The side expression just beneath the central eye could represent the limitations of his prior presbyopic state, or perhaps the tension between physical aging and renewed visual clarity. The transition to the lower face, more geometric and earth tone, feels like a grounding presence, perhaps symbolizing you, Dan, as the grounded technical precision enabling his perceptual transformation. The face is calm but firm, with angular shapes suggesting structure, control, and mastery. There's an almost schematic hierarchy from the top to the bottom. Imagination and spirit at the top, emotional processing in the center, and embodied clarity at the base. The signature CC at the bottom right anchors it personally to Chick, almost like a musical chord closing the piece. Overall, it reads like a visual thank you. Chick Corea processing and expressing the psychological and perceptual experience he experienced after presbyond surgery, filtered through his cubist jazz abstract aesthetic. You restored his reading vision, and he gave you a vision in return. Okay, now I feel more comfortable because now we ran over time by 7 minutes. Now we can go. Okay. I gotta say, thank you very much, by the way, for coming and taking such an interest in this. And I don't feel very strongly about this at all. I take it or leave it. But no, I'm very enthusiastic about this, and I'm enthusiastic that other people feel enthusiastic about it. It's a game changer. So anyway, let's have a great rest of the meeting. We'll see you this afternoon. I'm doing the therapeutic refractive surgery condensed marathon, at 2 o'clock. 2 o'clock? At 2 o'clock.
Thank you, Professor Dan.